My objective is to find synergy between the wisdom of academics and the community-based message of the Man vs. Prostate Crusade. The time is now for BPH-BPO care to prioritize the preservation of bladder health. Drugs temporize symptoms so we can triage and obtain bladder health baselines. The right dialogue, the right data, the right deobstruction allows us to intervene at the right time within the window of curability to prevent late-stage disease. My promise is that together we can affect positive change away from a drug-first approach to a data-first, pro-diagnostic, bladder-centric paradigm, allowing our patients to prioritize their bladder health, make the best decisions about their prostate even faster, and live their best lives chemical-free and catheter-free. The Man vs. Prostate tribe is built upon stories, with one story being told far too often. Returning home after a 16-hour day on the battlefield of being on call, collapsing into bed just as we drift off to sleep. The phone shatters the silence. It's the emergency room. This 70-year-old BPH, tamsulosin, finasteride for 8 years, can't pee, retaining 2 liters, catheters won't go in, moaning in discomfort. With a heavy heart and half awake, we return to this battle for the second time today. Same story, different patient. We're stuck in a loop, suffering patients, overburdened healthcare, burnt out doctors, bladders on the brink. The system is failing. Perpetually reacting to emergencies is not a solution. We need to come together, academics, community doctors, urology teams, pharmaceuticals, medical device industry. We need to synergize our efforts and our energy to save more bladders. Our success hinges on these following key insights. We are defenders of the detruser. We preserve bladder health, we prevent late-stage disease, and we end the polypharmacy epidemic together. We recognize that there are only 2 major organs that cannot be transplanted, the brain and the bladder. So we need to cherish this precious organ. We fight on the battlefield of male LUTs, where bladder dysfunction and damage is the main culprit for male LUTs, and we stand right here in defense of our queen, the bladder, to protect her from BPH-BPO, but we remain ever vigilant of other causes such as aging or neurologic or pelvic floor dysfunction or metabolic syndrome. We understand that good health policy comes from the right interplay between the right data, the right dialogue, and the right deobstruction. We remember that we are solution-finding surgeons that save organs, just like UPJ obstruction surgery preserves kidney function. For BPO, deobstruction preserves bladder function. We commit to this battle plan to preserve bladder health. On the left, an evaluation. With the right dialogue and the right data, we thoughtfully counsel, triage, and obtain bladder health baselines. And on the right, we do the right deobstruction, where we make the right surgical choice as we blend our trifecta of size, shape of the prostate, detruser function with shared decision-making 3.0, where version 1.0 was between the urologist and the patient. 2.0 was when the healthcare systems dictated what resources we had available, and then we invited the bladder for version 3.0 to take a seat at the table of shared decision-making as an equal partner with equal say in shaping decisions based on the 4 elements of good health policy, where solutions in the sweet spot of compromise are economically sustainable, with treatments that are effective and durable, optimizing a man's vitality, factoring in detruser function as it outlines the window of curability. Because we know this is a progressive disease, trust the truth of trabeculation, cellules, diverticuli as evidence of how BPO can progress to detruser underactivity. And we know that the bladder can only endure this assault from the prostate for so long before it reaches a breaking point. This classic 2020 study, 50,000 pressure flow studies, confirmed what we suspected. As that prostate grows tighter, the flow slows down, and as a result, the bladder compensates with rising pressures until it reaches a breaking point around the age of 62, after which it begins to fail and decompensate. If we use a missed indication age of 45 years and a Qmax of 10 cc's as criteria, we begin to see a window of curability emerge conceptually. And it prompts us to ask, can we intervene at the right time before the onset of damage or before the damage is irreversible to alleviate the symptoms and to preserve bladder health in these 5 clinical scenarios that patients and bladders experience? And it's much more than just the annoyance of a slow flow from BPO, but it's the anxiety of urgency, frequency, the exhaustion of nocturia, the shame and embarrassment of leaking down your leg, the terror of retention, and the deep anguish of a dead bladder. And we can begin to frame this within the 5 stages of bladder health, a decision-making aid, because BPH is about bladder health. The bladder is not transplantable, so we need to take care of it. Just like the heart is a muscle that pumps blood, the bladder is a muscle that pumps urine through the prostate that starts off about the size of a golf ball, but in the shape of a mini donut. So as the prostate gets bigger, that donut hole is going to get tighter, and things are going to slow down, stage 1. The bladder muscle will then struggle over years and become overactive, causing urgency, frequency, and nocturia, stage 2. If we don't take care of it, the bladder muscle will then act out like a rebellious child, contract without permission, causing urge incontinence, stage 3. And if we really don't take care of it, just like a heart can have a heart attack, the bladder can suddenly stop working, causing the emergency of retention, stage 4. And like the heart can go into heart failure, the bladder can go into bladder failure, causing a lifetime of catheters, stage 5. Worst case scenario, the heart can also still be transplanted, but the bladder does not have that option. Yes, this is an oversimplification where the transitions are not distinct. Stages can be skipped and stages can coexist. Yet it highlights how BPO can steadily progress to more serious stages. It highlights our shared goal to prevent late-stage disease, and it highlights the possible consequences if we choose not to take definitive action. As seen in this 2005 study, classic 141 men with proven bladder outlet obstruction on multi-channel advanced urodynamics with a follow-up of 14 years on average, reveals that the consequences are far more than just a decrease in flow and a decrease in contractility. And the real ramifications on bladder health is a 100% increase in stage 2 detrusor overactivity, 50% increase in stage 3 urge incontinence, and now 7 men are progressed into stage 4 retention when there were none at the start. The classic Flanagan randomized study 1998, looking at many men with moderate symptoms randomized between immediate TURP and watchful waiting, highlighting the importance of asking, is the decision to intervene, does that matter? And it confirmed what we suspected. The failure rate in the watchful waiting group doubled. We see that here from 28 to 58. But it reveals the deeper consequences of disease progression as we now see early stages going from 1 to 13. We see a doubling of stage 3 and almost a quintupling of the higher stages of stage 4 and 5. So yes, the decision to intervene matters. Moreover, the timing of intervention matters as well. And we see that with 27% of the watchful waiting group undergoing a delayed TURP. This group never caught up to the immediate TURP group. They did not fare as well. Well, who benefits the most from intervention? The upstream child cast some good insights on the most suitable candidate for deobstruction. And it's not those who are stage 5 with weak bladders or stage 2 or 3 with overactive bladders, but as those who have received earlier diagnosis in stage 1 with clear obstruction with BPO. Those bladders have a higher chance of being rescued, unlike at the other end of the spectrum with stage 5 detrusor underactivity. We're looking at this subset of men from this group of 19 men with atonic bladders who underwent maximal deobstruction with enucleation. Sadly, we could not rescue 21% of them, 1 in 5. So yes, the decision to intervene matters, the timing of intervention matters as well, and because it affects not just the quality of life, but what about the quantity of life? And we see that here in the Akurla study from Finland, looking at 3,000 men, suggesting provocatively a correlation between staging and the increased risk of death. We see here voiding symptoms alone, 1.2-fold increased risk, rising to 1.4-fold with storage symptoms, and now 2.2-fold with stage 3 urge incontinence. So yes, it asks us this question: does timely deobstruction save lives?